Hello, everybody. Sorry for the technical difficulties, and welcome to my home office. I just wanted to talk about the End of Life Choice Act and the implications for nurses. It is a very important, all as nurses actually really need to know well. So, as you all know, it was on the basis of Lucretia Seals, who died when she was 42 years old of a brain metastases. She was a lawyer. She was the one that first put the legal argument forward for assisted death. And what she was seeking and what we're all seeking as human beings is a good death. She was a very eloquent woman. She was a Pakeha woman. And I think that the law was made for a 42-year-old woman with brain mets, and that's a really important because that is not what all deaths are like. So the referendum was absolutely clear, and I just want to be really clear that the purpose of this presentation is not to debate the legitimacy of the act or to discuss whether the act is right or wrong. The purpose is to discuss the implications for nurses when it becomes law on the 7th of November. Now, one of the things about, I believe, the public perception about a good death, and this is just a general statement, is that most people think that a good death is in your home, when in reality, 75% of all deaths occur in an institution of some sort. And I think that that's an important thing to consider. The other thing to consider about dying in the home is some people's homes are not conducive they're not the suburban kind of home, and they often may not have a home. They may have a home that's not adequate. And so this idea that the best way to die is at home, I think really needs to be examined very closely. The other thing that's important to understand is that this yellow line here is basically deaths under 65 years of age. This orange line is those under 75 years of age. And this is the year that the law was enacted. And you can see there were very few people under 65 years of age that were dying at that time. And that number is going to diminish. This blue area is people that are dying over 85 years. In the future, very soon, and now it's starting. Believe me, I've done 2 death certificates this morning in the facilities that I work in. The majority of people that die will be old and frail, and that's the law does not really fit that population. This is actually what death looks like. For the majority of New Zealanders, death actually looks like when you are frail, when you are old, when you've had probably an extended period of months to years of frailty, and 50% of people over 65 will die in residential aged care. So again, you have to think about the law and how it actually fits reality. So the purpose of the End of Life Choice Act is to meet certain criteria and to provide a law for that criteria. These are the criteria. It must be over 18. You must be a New Zealand citizen. You must have less than 6 months to live. You must be irreversibly ill. You must have unbearable suffering, and you must be mentally competent. Those are I want to deconstruct some of those a little bit because they're not black and white in any form. And those of us that are nurses, and all of you are nurses, understand that this is not a black and white thing. So how does the New Zealand law, is it different than other countries? There is no stand down period. So that's not the case in Canada, and that's not the case in some US states. It is not only based on suffering, but also in the presence of an irreversible illness, and you must be determined to have 6 months or less to live. That is not the case in Netherlands and Belgium. It is basically based on your perception of suffering. It does not include mental illness. This is not the case in Netherlands, Belgium, and Canada. Non-residents are not eligible. This is not the case in Switzerland. We will not have people coming in from other countries for these services. A clinician can administer the medication rather than self-administration only. Victoria, Australia, the person must ingest the medication themselves. That's also the case in some US states. The difference here in New Zealand is that it can be clinician administered. The person must be mentally competent at the time of death. Now that's very tricky. Even for the 42-year-old with brain metastases, she cannot be delirious at the time of death. Unlike Canada, Belgium, and Netherlands, it cannot be post-dated for a future date when they no longer have capacity or by advanced care plan. And the last is it's not eligible. Anybody under 18 is not eligible. This is not the case in Belgium and Netherlands, where with parental consent, assisted dying can occur in children. So some of the gray areas. The gray area is you have less than 6 months to live. I work in residential aged care as a nurse practitioner. I have for many, many years. I was just asked on Monday, how long does mom have? I don't know. And the older I get, the more comfortable, particularly with frail older people, of saying, I don't know, we just have to take this a day at a time because I really don't know. This was some research that was done out of Canada, and it talks about the surprise question. The surprise question is, would you be surprised if somebody died in the next 6 months to a year? And that's been used in healthcare to try to get an idea who needs palliative care. But actually, when they did this research, what they found is that the surprise question performs poorly or modestly as a predictive tool of death. And basically what this, I think, illustrates is how difficult it is to predict when somebody has 6 months or less to live. I'm usually pretty good if they have less than a week to live. I'm horrible if it's less than 6 months to live. So I think that will present some problems as this law is enacted. What if I don't want to be involved? And that's a really important question. This is a very personal decision. And as we saw in the referendum, there were 2/3 of New Zealanders who felt comfortable with this law. One of the things I know in some of the professional organizations I've been involved with, we couldn't come out with a statement about being pro or against the law before the law was before the referendum, because there was just too much variety in opinion within our memberships. So absolutely, there are going to be nurses who do not want to be involved. So it's important to consider how you want to be involved now. This is 7 weeks away. You need to really wrestle with this question if you are on the edge. You are not obliged to participate in assisted dying if you have a conscientious objection, and that's great. However, and this is a really important thing, you cannot abandon the patient. Regardless of your personal beliefs about assisted dying, you should meet the professional standards by not inhibiting a person's access to lawful medical treatment and ensure that continuity of care is maintained for that person. That means if you don't feel comfortable doing it, you need to find the team that will be comfortable assisting this person with death. So the conscientious objection, the medical practitioner and other healthcare professionals like nurses that have conscientious objection, you must inform the person of your objection. You can't just ignore it or ignore the question or ignore the situation. Tell the person that you have a right to ask, this is a group I'm going to talk about shortly, for the name and contact details of a medical practitioner who is willing to participate in assisted dying. Suggest that a person talks to their medical practitioner or nurse practitioner about assisted dying and or direct the person to where they can find the information. That's where the continuity of care comes in. You must direct them to where they can get that information. The medical practitioner must ensure the person understands that there are other options, such as end-of-life care, palliative care. Now, this is where it's going to get really sticky really fast, and already has. The End-of-Life Care Act is silent on objections for organizations, e.g. hospices. So Hospice New Zealand took a judgment from the courts in a recent ruling. The state states that the organizations like hospice can object to assisted dying as set out in the End of Life Choice Act happening on their premises or by their staff. It is unclear if publicly funded organizations such as DHBs can decide not to provide the End of Life Choice Act services. So I would implore you to make sure, if you're in a leadership position at any healthcare organization, please make a policy now. This has far-reaching implications. It's not just that the organization says, so let's say an aged care organization like I work for. The aged care organization says, nope, we don't do this. I am obligated as a nurse practitioner to make sure that that person does have that service if they so desire. And then likely, if it's not going to happen on that premises, I have to find another place for them. And for a frail older person, that's really difficult. So who can determine a person's eligibility? Only a medical practitioner at this point. And then once that happens, that medical practitioner must find another medical practitioner to corroborate and to say, yes, I agree with you. So they must be competent at the time of the decision. Now, those of us that work in mental health or dementia care or other areas of practice, difficult competency evaluation is. It's not a black and white thing. It's not that they have dementia or not. It's that there is a continuum of competency. So I do believe that this will be a very difficult part of the law to enact at times. The Act includes safeguards to ensure anyone who seeks assistance to end their life is making an informed decision of their own accord. So what if there's a question? Then what needs to be decided and evaluated by a psychiatrist. So the psychiatrist will do an examination, will do a thorough investigation, and decide whether that person is competent or not. The tricky part is, like I said, is that you cannot be delirious at the time of the administration or of the procedure. So I've been fully competent. I've been really clear. I have brain mets. I go, and the last day when I've scheduled it, I become delirious. We cannot go forward with the procedure. There's also coercion. In my role is overseeing at least 1 to 4 deaths a week in residential aged care as a nurse practitioner. There are times when there is some pressure from the family, particularly when houses go for over $1 million in Auckland. Like, when is she going to die? We want the house. So there can be coercion that happens for people. What they're going to do, if the medical practitioner who is trying to figure out if this person is eligible, they need to talk to you. They need to talk to the nurses who are in regular contact with that person. They need to speak with the families, with the person's whānau. It is important has enough time and support to ensure that they understand the choice they are making. And some people are particularly vulnerable. If I am old and I have cancer, I've been deemed to have less than 6 months to live, I could, and I'm mentally competent, I could ask for the procedure, but we just have to make sure that I'm not asking for that, because people down the line that realize I have a lot of monetary assets, for instance. So suffering is in the eye of the beholder, and that's certainly been borne out in other countries. What is suffering? What does that mean? In New Zealand, it has been decided by the law that you cannot access assisted dying if you are suffering from a mental disorder or a mental illness, if you or you are of an advanced age. So I work with a lot of very old people, 95, 96, 99, who are tired of living there. But I could not, nor could any medical doctor say, hand on heart, they have less than 6 months to live. Therefore, and there's no specific irreversible condition other than being old. So they cannot access the procedure.
Fact is clear.
This is very clear, and this is what you need to be very clear as a clinician. You cannot raise the question of assisted dying with the person unprompted. However, if the person needs to, sorry, let me say this again. The person needs to raise this assisted dying question first. Now, research shows that nurses are frequently the very first people that are asked about assisted dying. So you need to have in your head what your stance is on it, and regardless of the stance, what information is out there. And the Ministry of Health websites are the best. They're fantastic. I got most of this from the Ministry of Health website. So the Ministry of Health website is probably the place to direct people for more information. Again, if someone asks you about end-of-life options, you can talk to them about other end-of-life care, such as palliative care. However, the Act is clear. You must not raise the topic of assisted dying unless the person is seeking an assisted death raises it first. So you can be involved as you personal beliefs and desires can meet. You can participate in conversations. You can discuss appointments. You can help people make appointments. You can talk to the whānau. You can be present during the procedure. All of those are allowed. You just cannot bring it up first. The role of the whānau is really important. I had a situation a few months ago where a sister of one of my patients who has dementia came in for a family meeting and said, "Oh, I guess I've got to start deciding about the End of Life Act for others." Like, no, absolutely not, on so many levels. Mainly because he did not have the capacity for that. And also the family cannot ask for this. It must come from the person. So, but they can still, of course, play a very vital role to that person, being there, supporting them, helping them through that process. And the other thing to remember, and I sometimes forget this, particularly in my role, is if the person gives permission, you can talk to the whānau. But that is so vital that the person must give their permission for you to talk to the whānau. And believe me, working with frail older people and daughters, it will not go down well if I have a competent 94-year-old with cancer who asks me about this procedure and doesn't want me to talk to his daughter. I don't know how I'm going to handle that yet. Who can administer the assisted dying medication? Medical practitioners and nurse practitioners. Not just willy-nilly, you have to be on a list. The person can also choose to self-administer the medication. So how are we making sure, what are the safeguards for this act? There are 3 levels of safeguard. The first is the support and consultation for New Zealand, the SENS group, or SCENS group, depends on who you talk to. There is also a check and balance at the start of the process and at the end of the process by a registrar. It's not that much different to me than the referee that reviews my cremation certificates. It's that same kind of procedural thing. And the end of life review committee then reviews what the registrar has. So there's 3 levels of safeguards. So the SCENS group or the SENS group, they maintain a list of health practitioners who are willing to be involved in assisted dying, and they maintain the standards of practice. We do have a nurse practitioner on that, Jackie Robinson, who is, I think, an excellent choice. She's a palliative care researcher. She's a nurse practitioner who's worked in palliative care and residential aged care. I just don't think you could get a better person from a nursing perspective. There's GP, urgent care physician. There's a disability sector auditor. There's an old age psychiatrist, Gary Chung. There's a pharmacist. There's a Māori educator. There's a Māori policy analyst from NZNO, Leanne Manson, and a social worker who's also who's an assisted dying researcher. So the registrar's job. The registrar check the compliance of the processes required by the Act. It notifies the medical practitioner of whether the process can continue or proceed, and it receives complaints, if necessary, to refer them to appropriate agencies such as Health and Disability Commissioner. And then the End of Life Review Committee considers the reports of assisted death of the person under the Act. So this would be coming from the registrar. The reports to the registrar on whether these reports show compliance with the Act. So this is basically the process. The process is this. The person asks to start the assisted dying and must record their wish in writing. Now, this also is not a black and white area. If they're illiterate or if they have some kind of disability where they cannot do it in writing, I think we haven't sorted that one out yet. The attending medical practitioner assesses if they are eligible. The independent medical practitioner assesses if they are eligible. If required, a psychiatrist is brought in for competency. The attending medical practitioner or nurse practitioner writes the prescription and informs the registrar. So after those first 4 processes happen, then I, as a nurse practitioner, depending on, or the medical practitioner, will need to inform the registrar. The registrar confirms the correct process has been followed, the person is confirmed as eligible, and then they choose when the medication will be administered. They make a date, basically. The pharmacist will dispense the medication. The medication is administered by either the doctor or the nurse practitioner, or self-administered by the person. And then the assisted death is confirmed and reported to the registrar. During the process, you can choose to withdraw from the process at any time before the medication is administered. If during any stage of the process it is decided that the person is not eligible, i.e. delirious, or other eligibility coerced, the medical or nurse practitioner must stop the process and explain the reason why the process has been stopped to the person. The medical and nurse practitioner must also stop the process if coercion is suspected. There will be a list of health practitioners who are willing to provide assisted dying services. This list will be securely and privately held and managed by the SENS group. Being on the list means a health practitioner may be contacted in different circumstances to take part in the assisted dying process. This means that if there is a conscientious objection by either a medical doctor or a nurse practitioner who does not want to be involved in the process, then it is their duty to direct these people to the SENS group so that they can find a provider who is willing to provide that service. A medical practitioner may be asked to be the attending medical practitioner in a situation where the person's medical practitioner has a conscientious objection. The medical practitioner may be asked to provide an independent second opinion. The psychiatrist might be asked to provide a competency assessment, and a nurse practitioner may be asked to administer the medication when there is nobody else that is willing to do that. So the take-home message is this. You've got to be informed. You can't go into this blind. It is going to get tricky. It has gotten tricky in other countries because the end of life is not black and white. End of life is full of gray areas. So we must be informed of the implications for our work and our institutions. And I would particularly encourage you to talk to your institutions now. What is your policy going to be? How are we going to handle this? There are very clear criteria regarding eligibility. If someone is likely to die in the next 6 months, you can discuss palliative care options, but you must not raise the topic of assisted dying unless the person seeking an assisted death raises it first. Two medical practitioners must agree on eligibility. The person must be mentally competent at the time of the procedure, no delirium. Medical and nurse practitioners can perform the procedure itself. And safeguards are in place from the SENS, the medical registrar, the end of life care review committee. So there have been set up legislative bodies to make sure that the law is enacted the way it was written. Really happy to answer any questions. Hopefully I went quicker than we were hoping, but I'm happy to answer any questions. I'm going to quit sharing my screen now, hopefully. Can you hear me? There you are.
Tēnā koe te ahorangi, Michal Boyd. Hey, he a tāhua tō kōrero, you know, it took me back to that kōrero about Maui. Maui tiki tiki ataranga, Maui the fisherman, Maui who slowed the sun down. And I got a little bit of a wish, I really, really wish that Maui had defeated death that day he tried. Unfortunately, as we know, he didn't. And so he kaupapa ngiha nui tēnei kaupapa akia tata katoa. So I'm just saying that this is a very big kaupapa for all of us right throughout the land and making those decisions and making sure that we've got the right information to make those decisions and that the person themselves is the one who makes that decision for themselves. So I'm just looking to the discussion forum to see if we've got any other kōrero or questions to come to you. At the moment, they're just saying, there's lots of comments saying, great presentation, very clear and informative. Thanks. Won't work, sorry.
Yeah, there are. So there is a really good question. So it takes 7 weeks, you know, this law will be enacted in 7 weeks. And this is something we don't know. The question is, how long does the process take? And frankly, we don't know. And there is no stand down period. However, knowing there is some bureaucracy, as you can see. So it's not, we don't know. It'll be very interesting because we haven't done this before in New Zealand. So it will be don't know. Good question.
Question from, I don't know if it's a question, might be a statement. We will need to be clear how we will have conversations about advanced care plans, etc. Without mentioning this, we need to have scripts. What do you think about that, Michael?
That's a really good question. Advanced care planning, in my opinion, is very different. You can't bring it up, of course, but if that person brings it up, you can discuss it and you can direct them to the resources online. So you can be really clear with them. You cannot put this in your advanced care plan. Bottom line, you can't. That's not how it is here in New Zealand. You have to have 6 months or less to live.
A very sensitive topic. This is from Liz. Are prisoners able to choose this if they meet the criteria?
Good question. Are they? Frankly, it's a really great question. And again, never been brought up. And again, you have to think about who this law was made for. It was made for a 42-year-old, very well-educated Pākehā woman. Very entitled, frankly, to tell you the truth. So what does this mean for vulnerable situations? If that prisoner has 6 months or less to live, let's say that they have cancer, absolutely, if they are competent. I can't see why it wouldn't.
From Eseta, thank you, Dr. Boyd. That popped out. There will be a policy developed by the Department of Corrections for that question, I suppose. Chris Whitefield. What about drugs? What will that affect the consent process?
Good question. It shouldn't. Again, this is a legal process. So the medications will be gained from a licensed pharmacy by licensed practitioners. So it shouldn't have any effect on that at all. That's why the criteria are so clear.
And this last question, and if you stay online, they'll keep firing the questions after we leave. So the last question we'll take here from Nadine. As you say, 6 months is hard to predict. What information do you think the public will be given? More self-directed research on EOL?
Yeah. Hey, look. I think personally, one of the things that has alarmed me the most is the misunderstanding of what a good death is and how difficult and gray that is. And also a misunderstanding of the law. It is not like, I think I even have a mother-in-law who might think that because she's old, she can access this law. So there's huge misunderstanding. And I think it's a nurse's role to very clearly describe what the law means.